of the Board of Directors September 2022 meeting. And will our General Counsel report on the actions taken in closed session?
Yes, thank you, Chair Wong. The board considered 5 items in closed session. The first was conference with real property negotiator. There was no reportable action. Item 5.2, conference with labor negotiator, also no reportable action. Items 5.3, hearing on the fourth quarter fiscal year 2022 quality report. No reportable action. Item 5.4, approval of the closed session minutes from August 25th. That was approved on a 5-0 vote. And the medical staff credentialing, which was item 5.5, was also approved on a 5-0 vote. And that concludes my report.
Thank you so much for that. Are there any deletions or corrections to the posted agenda? If by chance you have any, if you could raise your hand or at least use the icon at the bottom of the Zoom screen so that we know that you'd like to speak. So if there's no deletions or corrections, we'll move on to item 10, which is input from the audience. And this is the time in which members of our audience can speak on anything that's not on the agenda. You do have 3 minutes to present whatever you need to present to the board. Just know that we cannot respond other than acknowledging that we heard what you said because of the fact that it was not agendized. So is there any input from our audience at this time? I see no emojis or hand signs, and I don't see any hand signs up. So we'll move on to input from the Employees Association. Again, they're under the same guidelines as far as how long they're allowed to speak and that it's not on the agenda. Is there anybody from our either of our associations? Okay, seeing nothing, then we'll move on to item 12, our consent calendar. These are usually non-controversial items. They're reports from various members of our staff. They may be policies that have been updated, documents that have been updated, but certainly anybody on the board can pull one of the items under the consent calendar. Does anybody from our board have anything?
Chair Wong, I'm sorry, if I may, I do need to make a correction to my closed session report. Board member Michael McGarry was not present, so those votes were actually 4-0 votes and not 5-0 votes. So thank you, Martina, for bringing that to my attention. Thank
you for that correction. And we'll remember there's only 4 of us now whenever we vote, or at least this meeting. So the question I'd asked was, anybody want to pull anything from our board? If I don't have any board members, I'm going to ask to pull 12.3.3, the CNO board report, and we'll discuss that under item, I think it's 15 of our agenda. Anybody from our staff want to pull any of the reports? Okay. David, do I ask the audience if they want to make a comment?
Yes, if any member of the public wants to comment on any item on consent, they're welcome to do that. On the consent.
Okay, no hands seen. Then we're going to move on to item 13. And the first item we have under that is our.
Well, we need to make a. Oh. Do we want to vote on the consent?
That's right. Okay. So what I need is a vote for the consent agenda, eliminating 13.3.3, the CNO report.
12.3.3.
12, thank you. Okay, now that I've confused everybody, I need a motion to accept.
With the exception of 12.3.3, I move approval of the consent calendar.
And then, Mayor, I would second that approval.
Thank you. So Director Shamlin made the motion, Director Brown seconded it. And so approval of the consent calendar minus 12.3.3. Can we have a roll call
Director
vote?
Barnett?
Yes.
Director Shamblin?
Yes.
Director Brown?
Yes.
Director Wong?
Yes. Okay, so we'll be coming back to one of the agenda items. On 13, this is board action, and this is where we're going to have the fiscal year 2021 Moss Adams single audit report. And we have Justin Gomez and Kate Jackson from Moss Adams to give us the audit report.
Perfect. Thanks so much. Justin, did you want to go ahead and share the report with everyone? And we're just going to share a snippet, not the full audit report, and we'll kind of walk through how it'll get put together. But these are the additions to what was already issued with your financial statements. It's called the single audit reporting package. So the first thing that we just want to highlight, and Justin, can you go down just a little bit, is the change to this report that was issued with your 2021 financial statements. And as you probably are all aware, we definitely talked about this early on. This has to do with the additional federal audit that we had to do because you received over $750,000, mostly related to the provider relief funding. So we had to do a single audit and test that for compliance and make sure it was spent for in accordance with the terms and conditions that were prescribed. So the main change, if you want to just scroll down a little bit more, is this addition, this paragraph that Justin just ran the mouse around, and that just refers to an additional report that we have to issue, and it's a report that's in accordance with government auditing standards, and it refers to the date that actually was issued with your financial statements. We just didn't necessarily present it, so that is included, and that's dated at the same time as the issuance of the financial statements. And then you'll see one additional report that we'll cover with you that has to do specifically with the compliance and internal controls related to the federal awards. So with that, is there any questions before we even get started? Because I know we're talking about something that's happened a long time ago. So it's definitely later. And this is also due to the delay in the guidance related to these that was released just recently. So we've been waiting on that guidance for a long time. And so that was the reason why this was delayed.
Kate, Dale here. Were we able to justify the use of all those funds, or were we required to return some?
And that's a great question, Dale, and we cover that in the report, but we did have to return about $5 million in funds. So you were allotted about $13 million, and $8 million of those were used in accordance with the terms and conditions of the grant, and about $5 million was returned. And that's noted in the notes to the schedule of expenditures of federal awards. Yeah, because there's a reconciliation between the gap and also obviously what was actually used in accordance with the terms and conditions, and then that the portion was refunded.
Do we actually have to write them a check, or can we work it off through Medicare, Medi-Cal?
I have a feeling you have to write them a check. But I'll ask. I don't know the mechanics of that, so I'll let Crystal speak to that.
So the funds were absolutely returned way back in November, I think it was, when the first reporting period was required. And because of how the government has things set up, they could only handle $1 million at a time. So we I know we had to make 5 $1 million transfers to them to get it all to reconcile. So it was kind of an interesting process.
Oh, God. Okay.
Yeah, and if I remember correctly, Crystal, I think you had a certain amount of time from when the reporting closed in order for you to make any repayments back. And I want to say it was like 30 to 60 days that you had to refund everything that you didn't use after that reporting period closed. Yeah.
Well, what was ironic is we paid it all back, and then about 6 months later, we got a notice that we didn't pay them, and I was like, "What?"
Oh no, that's horrifying.
They were seriously behind in doing their reconciliation of those that actually returned funds. So they said if I didn't hear anything after that, we were good, and that's kind of a scary notion coming from the government, but apparently,
yeah. Any other questions? That's a great question, Dale. Any other questions before we continue with the report? Okay, go ahead, Justin. You can cover the remaining additional items.
So yeah, I'm just going to cover here the kind of additional and supplemental information that you're going to find attached to the end of your 6/30/2021 financial statements. And so the financial statements themselves remain intact. Nothing is going to change on that. The only thing you're going to notice is you're going to see this page starting at the end of your statements, as well as all these reports that I'm just about to run through here. This first one's really the only schedule you're going to have in here, and it's a schedule of expenditures of federal awards. And what this is highlighting and detailing is it's pretty much showing you the amount of federal awards that were expended during the year. And so for this component as it relates, you're going to find that the majority of it is related to the provider relief funds. That was the only major program of in excess of $750. And that's that 8.1 million there. And so that's really the purpose of this schedule. Going down here is really just the notes to the schedule of expenditures of federal awards. Very similar to financial statements, there's always notes attached with it. And so these are kind of the notes that support that schedule. And in there, you'll kind of see the documentation where the total amount that was received, the total amount actually expended, and then the remaining portion is what's ultimately remitted back. And really what to kind of highlight there, and one thing I wanted to make sure to clarify is the portion that was refunded was not due to an error in using the funds or any of that. It was, they could not meet the terms and conditions as far as having qualifying expenses or lost revenues. That's not necessarily a bad position to be in. It just means your organization has done a very good job of sustaining its operations, generating profit through COVID-19. That's not the case for, I see the majority of my clients had significant lost revenue. So to a kind of a degree, it's actually kind of a good thing to see that the business itself was doing so very well through those tough times. But yeah, like I said, very brief here, but notes to the schedule. This next one here is the government auditing standards opinion, and it's our report on financial reporting over internal controls, as well as the compliance aspect. This is also something that was technically issued last year. It might not have been delivered in the package, but as part of issuing the financial statements last year, we did have to, at that point in time, get comfortable that they're adhering to government auditing standards as it relates to internal control over financial reporting. And so it really just talks about our opinion, clean opinion here. No issues to note on this one. Rolling on to the next report. This one is really a report on internal controls and compliance, but as it relates to the uniform guidance, specifically the cost principles aspect of it. And really, this report too, same thing, clean opinion, just talks about we didn't find any instances of being out of compliance as it relates to the terms and conditions of the award. And so clean opinion on this piece as well. Moving through, this is what's called the schedule of findings and question costs. This is where you would note if we had any issues, anything and kind of discovered throughout the audit. You'll notice as you kind of look through here, if there was material weaknesses, deficiencies, you're going to note all of those are none. So if there are any issues, you would see that here, as well as there would be additional reports that would follow. But yeah, kind of highlights that here. Really,
Justin, can you pause for just 1 second? Because it is a little confusing, but it's a great summary report. It's almost like a scorecard, if you will, of a single audit. The first part there has to do with any internal control findings related to the financial statements themselves. So that would be noted in that GAGAS or that government auditing standards report that Justin just went through, and that has to do with just your financial statements. And then the middle part has to do specifically with your federal awards. And that would be where we would note any compliance related findings or material weaknesses or significant deficiencies related specifically to your federal awards. And then below that, it tells you what specific program we tested and then what the opinion was related to that. And then finally, the threshold between distinguishing what would be considered a major or basically a type A or type B program. Major would be anything over $750,000, which just means it requires us likely to test it. And then finally, the last thing that usually people look at is the auditee qualified as low risk or not. And that just drives the threshold of expenditures or testing that we have to do as your auditor. And because you haven't had single audits previous to this year, that's why it's considered not low risk. So, you haven't had to do it before also. So you have to have had 2 years of clean single audits before you can qualify as low risk.
Right. And then last page really is just stating that there was no financial statement findings and no federal rewards or question costs identified. And that is the extent of all the additional reports associated with the single audit.
Okay, Dale's got his hand up.
Yes, Justin, I really appreciate you providing that benchmarking comment, comparing us with comparable hospitals. Is there any one thing or group of things that stands out in your mind that differentiates us other than profitability, but specifically the reasons for it?
And Kate, would you have anything specific on that?
I would say that your revenue didn't suffer. You still had people coming to Tahoe, and other organizations had high dependence on elective surgeries. And so when those were shut down, they suffered greatly as a result. In addition, you did have your PP&E go way up, and so did they, but they just weren't able to recover with regards to their revenue as quickly as Tahoe was. So you were able to kind of maintain revenue, even though you had that increase in expense, or actually increase revenue, I would say, for the most part. I think you only reported 1/4 of lost revenue in your lost revenue calculation compared to 19, which is amazing. I would say most of our organizations could report for the entire period lost revenues for almost every quarter. So they're struggling very much so with lost revenue. And that would probably be the biggest differentiator from you versus them, is you were able to maintain or increase revenues and they were not.
And that was the biggest reason why we had return funds, Dale, is the amount of funds we received. We just didn't have the lost revenues like other organizations had. There's only a handful, not even a handful of hospitals I know that actually had to return funds, us being one of them. You can count them on one hand. So we did very, very well, very methodical in how we addressed COVID, how we chose to, either keep services open or methodically shut them down and then open them back up again. So we fared very well.
Yeah, and I would also say, Dale, that Tahoe is definitely a place of refuge for most people during COVID. It was one place that was open.
Yes.
I know I had a lot of friends that were up in COVID, or up in Tahoe during COVID, because it was the one place you could go. So there's also that you had going for you for sure.
Yeah.
People were trying to escape.
And they did.
And they did, yes.
Okay.
Yeah.
Is there anybody else that would like to make a comment on the single audit? Anybody from our audience that have any questions or comments for our reps from Moss Adams?
Ellis, I have a comment on how nice that explanation was. And I fully understood it, and I appreciate it.
Yep. Okay. What we need now is a motion to, is that to a motion to approve the report or to accept the report? Martina?
Yes, if you guys could make a motion to approve the fiscal year 2021 single audit report as presented.
Okay, thank you. So can I have a motion?
So moved.
Okay. A second, please.
I'll second, Dale.
Okay, so it's moved by Director Brown, seconded by Director Shamlin to accept the fiscal year 2021 Moss Adams single audit report.
Director Burnett?
Yes.
Director Shamblin?
Yes.
Director Brown?
Yes.
Director Wong?
Yes. So the report has been approved as given, and I want to thank Kate and Justin for coming up and explaining that to us, and also to thank our administrative staff who led us through some very difficult years and kept us in the black. So thank you, Crystal, Harry, Louie, everybody. Then we'll move on to item 13.2.
Yep.
And this is a resolution, 2022 and my dash 17. And Alex, do you want to go ahead and present?
Thank you. Yes, Alex McLennan, Chief Human Resources Officer. And we have been working on this resolution for quite some time now. We had a document that was about 35 years old. It was created in 1985. And as you know, our health system is much different than it was back in 85. And so with the help of our Labor Council, Rick Rybicki, as well as the unions, we developed a new resolution. And I'm going to introduce Rick Rybicki, again, from Rybicki and Associates, who is our Labor Council, who can walk you through kind of the details of why and why we wanted to update that and some of the changes.
Yeah, thanks, Alex. So I'm Rick Rybicki. I'm a labor lawyer who's been working with the district for some time. And the current ordinance that we have, the labor relations ordinance we have, is what sets the procedures for our local district for labor relations with employee representatives, or what people would normally think of as a union. And the ordinance, like Alex said, has been here since 1985, which is a very long time. In the old ordinance, which is the current ordinance, refers only to the Truckee Hospital. And it doesn't reflect the spread of the Tahoe Forest Health System to different locations, different services, different types of employees. And it also doesn't have a lot of the more common types of petitions that organizations and even management are likely to bring. So there are big areas that are just not addressed by the ordinance. Everybody has recognized that for a long time, and as long ago as in 2008, the unions, both the in-house associations and human resources, had a memorandum of understanding with each association that we were going to work on and create a new ordinance, and it just hadn't happened. So the new ordinance covers all these issues. It incorporates a lot of the current standards that we have in California, Myers-Milius-Brown Act relations, like some card checks that are required, different types of petitions that weren't addressed, and the types of things that appear in the fairly new PERB regulations, which were adopted after 2000, which was a long time ago, but was still 15 years after the current ordinance was adopted. So we think that this is a pretty good, pretty modern, pretty standard set of rules, and it has been reviewed, and we've met and conferred with both the Employee Association and the Employee Association professionals, and they both signed off on it. So we think everybody supports this change, and it's going to be good for the district. And, you know, I'd recommend that we adopt it so we have something that moves us into the future.
Thank you. And I did want to remind you that both EAP and the EA, the two employees associations, have signed off on this. So they're in agreement with what is in the document.
Correct.
Is anybody on the audience? I think the board has had an opportunity already to address both Mr. Becky and Alex, but are there any other questions or concerns? Because then I'll open it up to the audience for any questions or concerns. Seeing no hands, then we have a resolution that's been put before us in regards to the Board of Directors of the Tahoe Forest Hospital District establish revised rules and regulations for the administration of employee relations. And this will be Resolution 2022-17. So we need a motion to approve that resolution.
So this is Director Barnett. I will so move, and I just want to say that this was a collaborative effort over many years, and I just want to say that seeing a collaborative effort like this between the employee associations, our council, and our administration and staff is very heartwarming in this age where there is sometimes contentions that are probably unnecessary. So I think this is just a really good piece of work.
Thank you. So Director Barnett has made the motion. Can I have a second?
This is Mary. I'll second.
Thank you, Mary. Director Barnett has moved and Director Brown has seconded that the Board of Directors approves the Tahoe Forest Hospital District establishing revised rules and regulations for the administration of employer-employee relations. And can we have a a vote on that, Martina?
Director Barnett,
Yes.
Director Sandlin,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So the resolution has been passed. Thank you so much, Alex and
Thank you.
Mr. Rebecki, for the work that you've done with our associations to get this current reg set up.
Thank you.
Then we'll move on to 13.2 and I'm sorry, 13.3. And this is the first reading of proposed revisions to the Tahoe Forest House of Board of Directors bylaws. And the Governance Committee has reviewed the bylaws. They've made some editorial changes. They've also made some substantive changes, and I'll go over those with you very quickly. On page 5, we added a statement about appointing a candidate to a vacancy without having to go through a public solicitation. In the past, we've always gone to the public, and it just holds things up. And if we have somebody that we know would be a good fit with the board for a vacancy, we can't appoint them without going to the public. Then on page 6, the regular meetings, we put into the document that in November and December, our regular board meetings will happen on the third Thursday of the month of November and December. So it does not conflict with the holidays. And this is something that traditionally we've done every year, and every year we tell everybody we're doing it. So we just want to codify that this is what we do. And then on page 8, under duties of officers, now we have the Board of Directors chair serves as a chairperson for the Board of Governance Committee. And that's because, again, the governance and the chair are really one and the same. And then under treasurer, now it says that the treasurer serves on the finance committee, but not necessarily has to be the actual committee chairperson. So those are the substantive changes. There's some other things that are technical and have to do with grammar, et cetera, et cetera. So that is our first reading for it. And then it'll be presented, unless someone has a comment or question about the bylaws at this time, we have to present it again a second time before we approve it. So are there any comments or questions about the bylaws as they've been presented with the potential changes? Okay, Dale.
Alice, Dale here. I should mention that I raised an issue that was answered by David, our attorney, in regard to number 5, vacancies, where it says the board may appoint an individual without engaging in public solicitation. But then it goes on to say that notice
that we can.
Pardon me?
That we can do it if we need to.
Yeah, notice of the vacancy shall be posted. Well, to me, that seemed to be a solicitation. So I was a little bit confused by that. And David, I think perhaps if you could re-explain that to the group and me as well. That's not a contradiction.
Sure. Yeah, so when there is a vacancy, we are required under the government code to post a notice and to inform the county registrar of voters of the vacancy. That is separate and apart from the manner in which the board decides on who they want to appoint or how they want to appoint. Because you can also do a special election. You don't have to appoint. Yeah. So what this board has done in the past, you post notice of the vacancy. I mean, that's what Martina does. That's what the clerk does.
Yeah.
But then the board often was giving direction to then go out, put things on the website, maybe put something in the newspaper, put something on the bulletin board and solicit applications, prepare an application form that is a solicitation. And so what this bylaw amendment does, it says you don't have to do that. If you already know of a candidate that would be a great appointee, the board has the power to simply make that appointment. It still has to comply with the government code by posting the notice and informing the registrars of voters. Does that make sense?
He still has his brow furrowed. Are you okay with that, Dale, with that explanation, or is it the wording of shall?
After hearing it a second time from David, it makes a little more sense, but I see Ted's got something to say about it.
I do. Thank you, Director Chamblin. There are times, for example, where a vacancy may come about where expediency is of great importance. Okay, it might be at the close of a term, for example. The board is not required by the law to go through the public process, but you're giving yourself the opportunity to do that if you wish, or to choose a candidate of your choosing when you need to. So I think we're, as David pointed out, well in accordance with the law, but it gives you some flexibility, giving the time or period in which a vacancy might come about.
So it's just another option that the board will have to fill a vacancy. And all of the proposed editorials, as well as the substance changes, have gone through legal counsel to make sure that we're in compliance with all the rules.
I have a city that's dealing with this right now because there's an election coming up, and there was an individual whose term was ending, and they took another job and they had to resign from the council. And so there's basically like 4 meetings that they need to fill until that appointee's term would even end. So in that sense, in that case, expediency can often be helpful.
Alice, I just wonder if we're setting ourselves up for criticism if we post the information or post the vacancy, but then immediately select somebody without really doing a thorough vetting process in the public. And that's the thing that concerns me more than anything. The legality of it, I understand. The optics of it, I don't understand.
Go ahead, Ted.
I would say, Dale, that this gives you the flexibility to make a decision in a situation. You might have some criticism in that, and maybe you don't. But it gives you the opportunity to act given the situation and the timing of the vacancy. It's a tool in the toolbox that you have very recently needed, but we did not have.
Yeah.
Okay. I'll buy it.
Right. And again, it's something that may never be used, Dale, or it may be something that in a circumstance that we will absolutely need, and we have somebody that we know would be a good fit on the board for a short period of time. Okay.
And I just hope we make the decision keeping the optics in mind.
Yeah. Okay. Any other comments from the board about the bylaws? Okay. Any comments from our audience? So again, it's our first reading, and we will have it posted again in October for a vote. Now we have 14.1, and this is education for the board on the No Surprise Act. And we want to thank Crystal, who postponed the presentation last month, so we weren't there till dark 100, and is going to do it for us today.
Well, it should have provided you plenty of time to review the material, so we'll pretty much just hit the highlights, and I am going to go ahead and share my screen.
You know what, before we do that, I'm sorry, can we at least get maybe a motion to introduce the bylaw amendments, just so we have that on the record, essentially as a first reading? Is that okay?
Okay, if that's what we need, we can do that. So we'll do that very quickly.
And Chair Wong did have one typo, and it was on page 16. It looks like one of the regular meetings that was supposed to be put to lowercase is actually an F instead of an R. So we'll correct that for the next version that comes next month.
Okay, so what should our motion be to
Introduce the bylaw amendments.
Okay, so want to introduce proposed revisions in our Tahoe Forest Hospital Board of Directors bylaws, and will be presented for a second reading in the following month. So can I have a motion?
I move what David said.
Okay, a second to the motion.
I will second whatever David said.
Move to introduce the bylaw amendments as presented with the additional typographical error that Martina noted. That's all.
Okay, we've got that recorded. So Martina, can we have a vote?
Director Barnett?
Yes.
Director Shamblin?
Yes.
Director Brown?
Yes.
Director Wong?
Yes. So we'll be revisiting that next month.
Thank
Now-
you for indulging me.
Thank you for correcting us. So now we'll go back to Crystal.
Okie dokie. Are you seeing the slides?
Yes.
Yes.
Wonderful. So this is going to be a brief overview of the No Surprises Act, which is federal, and AB 1020 and 532, which are state. And I'm kind of combining all three because they're kind of linked to each other in several ways, which you probably saw if you read through the material. So we'll start with the No Surprises Act. This went into law December 27th of 2020. The whole idea behind it was to protect the patients from surprise medical bills, as well as providing a level of transparency around cost charges, what their insurances cover, et cetera. It applies to both healthcare providers and healthcare plans and air ambulances, but I am not touching on any of the air ambulance stuff in my presentation. They get to worry about that, not me. Almost all the sections of the legislation did go into effect on January 1 of 2022. There were a few areas that have been delayed in implementation or going into effect, which we'll touch on as we go through the slides. So first, we're going to really talk about the provider requirements. And one of the first ones is related to out-of-network healthcare providers. Out-of-network simply means that the healthcare provider has not contracted with that particular health insurance plan. So that is what out-of-network means. They're not contracted. So if patients come into a facility that doesn't have a contract with their insurance plan, you are an out-of-network facility. So in this case, out-of-network healthcare providers, whether it's a doctor or a facility, cannot balance bill patients for covered emergency services or certain non-emergency services provided at an in-network facility. And what's meant by that is, say Tahoe Forest Hospital is in-network, so we have a contract with the insurance plan, but there might be a doctor who's performing services in our facilities who may not be contracted with the plan. And that's what that section is talking about, unless we go through a notice and consent process. The other thing I want to touch on here is what exactly is emergency services. So technically, that is the time that a patient enters the emergency room to the point of when they're stable. Now, it would be pretty challenging to be able to run into the emergency room and tell the patient, okay, you're stable now, so it's no longer under the No Surprises Act. And we'll talk about that in a minute, how we would handle that. But there is a cutoff point of when emergency services begins and ends and when post-stabilization kicks into play. So in certain circumstances, if it is out of network, we can approach the patient and get consent to bill or to treat and bill from the patient. But there are certain circumstances where that doesn't apply. So emergency services, like we just talked about, there are certain ancillary services that we also cannot balance bill for. So if some of the imaging services, lab services, pathology services, especially when they're connected to an emergency service, you cannot balance bill for those. And you can try to get consent, but you have to know the cutoff of when the emergency ended and the post-stabilization began in order to approach the patient to get their consent. So it can be very difficult to try to do that. You have to get the consent within 72 hours of the service being delivered. It can be paper or electronic, and you can see that that consent has to have certain criteria. You have to notify the patient that, hey, we're an out-of-network provider. We have to give them an estimate of the charges. We have to provide them a list of in-network providers at the facility. By the way, if there are no in-network providers as options for the patient, you can't balance bill, period. Consent doesn't work. So you have to have the option of in-network providers in order to get consent. So they made it pretty detailed of the steps you have to go through if you were to go and balance bill the patient for services you would be allowed to do that for under the consent process. So, and we have to have it available in the 15 most common languages spoken in our area. So, thank goodness that's kind of a narrow list for us. Other requirements, from a disclosure point of view, we have to make the protections provided to the patients under the No Surprises Act publicly available to them. Has to be on our website. We provide it in writing to them upon when they show up in the emergency room. Matter of fact, I just brought my daughter in the other day to the emergency room. She broke her ankle. Sure enough, we got the disclosure on the balance billing. So I do know for sure we are in compliance with that. Moving on, transparency. This is where things can get a little dicey under the No Surprises Act, is providing good faith estimates, which everybody gets tired of saying that, so they refer to as the GFE. So when you see GFE in the slide, that's what it's referring to, is the good faith estimate. We must provide that to a patient if they are uninsured, period. And we're supposed to be providing the estimate to the patient's health plan. Now, that item number 2 has been delayed. The reason it's been delayed is no one's figured out exactly how the process and communication between the provider and the health plan is going to work. So this is the component of the No Surprises Act that has been delayed, and we are not currently doing number 2, where we're providing estimates to the health plan. You can see in the next bullets, it's all based on timing. So if it's scheduled, we have to do it within X number of days. If it's within a narrow scope, we have 1 day, et cetera, et cetera. So there's a time frame in which we have to provide those estimates. And the estimates have to provide the total expected charges for the services, not only the services that the facility would provide, but any of the professional fees as well. And even those that we may not be billing for. So like pathology or maybe the emergency room physicians, we don't bill for those. And so, but we still have to estimate those charges. So it gets very complicated. We have to give them billing and diagnostic codes as well. And we have to give that to the patient, and eventually we'll have to give that to the health plan if they're insured. So that's our responsibility as a facility or as a provider. So if we provide an estimate to an uninsured patient and the bill ends up being substantially higher, there has to be a dispute resolution process for that patient to go through in order to rectify the variance between what we estimated and what actually got incurred. Currently, we're being very kind of generous with that process through our existing financial customer service program. So we already kind of had that in place when there was disputes, and that's worked well for us so far. And you can see they defined for us what's substantially higher. It's only a $400 variance. So actually, there's not a lot of room for error. So we tend to err on the high side and expecting the bill to probably come in, if not that high, lower. So we don't have that $400 variance that we're disputing all the time. And then we have to keep this for at least 6 years as part of the patient's medical record. So it sticks around for a long time. So this next part is from the plan's perspective and what they're responsible for. So they're required their requirement is related to emergency services, including that post-stabilization that I talked about. And when we say unless certain conditions are met, that's that consent process. So unless we got consent, then things change. And then, of course, the non-emergency services by out-of-network providers and in-network facilities. So they're dealing with the same issues the providers are. So the health plan, they're required to cover emergency services without any prior authorization and regardless of whether we're in or out of network. So the health plan must cover that emergency visit. Mm-hmm. When provided as an out-of-network provider, the health plan must cover those services without any kind of additional ties. They can't be more restrictive about, utilization management. They can't apply more cost sharing to the patients. They have to treat them as if they were in network. And so they can't mess around with us, the provider. They still have to pay us within 30 days of receiving the claim. However, there can be a dispute on what the plan feels they should pay as in-network to an out-of-network provider versus what the provider might think they should have been paid. So, but regardless, it has to be paid within 30 days, and it has to be directly to the facility. They can't push it through the patient. And you can see kind of the other items here. And we must have a dispute resolution process if we can't agree to payment terms. These are the same criteria that apply to the emergency services part if services were provided by an out-of-network provider at an in-network facility. So the hospital's in-network, but the provider's out-of-network. Same thing. The cost sharing has to be as if it was in-network. They still have to pay within 30 days. There has to be a dispute resolution process. The in-network benefits must apply on the health plan. So again, preventing that balance billing from occurring. The transparency on the health plan side is they were required to modify insurance cards. So now if you were to look at your insurance card, it should show your in-network responsibility and out-of-network responsibility, your maximum limits, and a special telephone number you can contact if you need additional information, especially if you're trying to find an in-network provider. So they were required to modify insurance cards. In addition, health plans are now required to send to their patients what's called an advanced explanation of benefit. So this is kind of where the component on the provider side that I spoke to you about having to provide an estimate to the insurance plan. Well, this is the insurance plan's requirement. So if there is a scheduled service, the health plan is required to provide their covered person an AEOB. And if it's in network, they have to provide what the contracted rate is, what the codes would be, and they get all that from us, the hospital. So that GFE that we send to the health plan, they take some of our information and they put it in the AEOB to their covered person. It gets complicated. So in that AEOB, you have to have the health plan have to put the expected charges, the codes that was sent by us, what the plan's payment responsibility is, what the cost sharing is to the patient, how much is going to go to their deductible or out-of-pocket deductibles or maximums, whether or not it needs authorization. And so they're required to disclose all of this to the patient. Now, again, this part of the No Surprises Act has been delayed because they have not figured out how to do this between the provider and the health plan to the patient. So it gets kind of complicated. Part of the requirement is once this goes into effect, it could be mail or electronically provided to the patient, whatever they prefer. You can see they have to adhere to certain days in which to provide it to the patient, depending on when it was scheduled. But again, the Department of Health and Human Services decided not to enforce it at this time. So it has been delayed. That's why none of you are seeing this for anything you have scheduled, because it's not implemented yet. Oh, what happened? Oh dear. I may have to switch here. The rest of the presentation has disappeared.
It's working now.
Oh, is it?
It was. It's blank now, but it was working.
Yeah, page 15 has disappeared. Let me see if I can grab another copy of this that has it there. Okay.
Crystal, I have it if you want me to take over.
Sure, that would be fine.
Starting with key takeaways, or what's the next?
So I would be on, key takeaways.
Would be next. Okay.
Yeah.
Perfect. Thank you, Martina. So this basically just summarizes everything we went over. And, you know, there are some other small nuances in the No Surprises Act, but these are kind of the big highlights. If we move on to the next one, we'll get into AB 1020. This is applicable to the state of California. It's referred to as a healthcare debt and fair billing bill. It went into effect on January 1 of 2022 as well. This existed in the past, and what AB 1020 did is modified an existing legislature. So if we could go to the next page. Okay, so the existing law required us to provide public awareness that we have a charity care financial assistance policy for the uninsured. We have a prompt pay discount, and that there are government-sponsored health insurances, covered California, et cetera. So we're supposed to provide public awareness of those items. It standardized the billing and collection procedures, requiring X amount of time to transpire before we could send someone to collections. They had to receive 120 days worth of notices or 4 statements worth. So it really standardized what steps we had to take before we could send someone to collections. In our charity policy, it also, the maximum amount was 350% of the federal poverty level. And it generically said high medical costs. So there really wasn't a definition to what was meant by that. And then all hospitals had to, in essence, provide this information to HCI. That was OSHPD for those of you that have been in healthcare for a while. They changed their name. So when we say HCI now, it's actually OSHPD. So, and then CDPH, California Department of Public Health, enforces the compliance of this law when they go through our facility licensing. So that was the existing law before 1020 came into effect. Let's go to the next slide. So 1020 changed some of that existing law. So it changed the 350% of the federal poverty level to 400%. So that allowed more families to qualify for financial assistance under the Charity Care Financial Assistance policies. It also allowed us the ability to go beyond 400% if there were certain circumstances that the hospital felt that financial assistance should be granted. So that flexibility wasn't there before. It also defined what high medical costs meant. So any annual out-of-pocket cost of the hospital that exceeds the lesser of 10% of the patient's family income or the family income in the prior 12 months. So we now have definition to what they think high medical costs are. So that was a change. They imposed new notice requirements. We have to display the policies on the website and actually link them to the actual policies so patients can actually read our true policies. And we must send a notice to the patients with the application for financial assistance before we can even start anything from a collections process point of view. We can't sell the debt unless due circumstances come into play, and we can't credit report for at least 180 days after the first initial billing. That used to be 150, so they extended that timeline. And we must submit our debt collection policy to HCI. They are looking for that every other year on even years. So they define that for us as well. And next is AB 532 that kind of piggybacks on 1020. It's the fair billing policies. This went into effect January 1 of 2022 as well. This had, like I said, if we go to the next slide, you'll see similarities of 532 with 1020. So the existing law was, again, maintaining policies for discounts and charity care, post them in locations so it's visible to the public, that we can negotiate discounts with eligible patients. Those are usually the uninsured. That we give patients notice that we have a discount payment and charity care policy. And upon request of a person that has no health coverage, that we provide them an estimate. Well, you can see we have to do that now. A written estimate of the amount a person without health coverage would pay for the health care service and give them an application for financial assistance. So that was what the law was before 532 came into play. And then 532 changed that, if we go to the next slide. So now all our notices about discounts and charity care policies, we must provide an internet address for the Health Consumer Alliance. And these are organizations that help patients understand billing and payment processes. We have to give information about Covered California, Medi-Cal presumptive eligibility, which we do participate in. We got to give them the hospital's list of shoppable services, which you guys had previously seen, that we absolutely have that transparency on our website. And that instead of making a patient ask for an estimate, it requires us to provide someone who is uninsured with an estimate and requires us to automatically give them a financial assistance policy without ever requesting it. So you can see how these tie in to the No Surprises Act as well. So those are kind of the high-level laws that went into effect on January 1 of 2022 that we continue to do the best we can to fully implement. I will tell you, the final ruling of the No Surprises Act just came out. CHA is doing a webinar on September 30th to go over what the final rules are. So there is definitely more to come on the No Surprises Act. That's all I got.
Well, that's enough. Wow.
Crystal, Dale here. Somebody comes in and got a broken leg skiing or biking, and they're in the ER, don't have any insurance. Are they billed at the charge master rate?
They are. So whatever our charges are is what creates that estimate for them. And we offer them what we call the prompt pay discount. So if they pay at time of service, that is discounted by 30%. Most people that come into the ER that are uninsured, typically we either get qualified for Medi-Cal or they usually qualify under the charity care financial assistance policy, but it requires them to follow through on filling out the application and providing the backup documentation that we need to validate income, et cetera. So most of those folks fall into those categories.
You also said that you could get the information to them about Covered California, but would they handle the claim retroactively if they signed up? No. Okay. I remember you telling me at one time when I asked, has anybody ever paid the hospital the full charge master rate? And I think you said one time you had somebody from a foreign country come in who was wealthy and had services and had no U.S. coverage, and yes, did pay the charge master rate, but it's really rare.
We actually had a patient from the Bay Area who was up in our area and sustained an injury and needed surgery, and paid in full for one surgery. They ended up having to have a second surgery, and we negotiated the second surgery with them since they paid the first one. But they purposely made a decision to not purchase insurance and was prepared to deal with their bill. I mean, that is like extremely unusual.
Was it Mark Zuckerberg by chance?
I couldn't tell you anyways, Dale.
Yeah, right. Okay, could you also give us an example of probably a more common situation? A skier, a biker comes up from the Bay Area. They've got Kaiser coverage, and they've got a broken leg. Out of network, I assume. But Kaiser is going to pay for the emergency costs. And then you've got to make some determination whether you pack them for travel, I suppose, and get them down to Kaiser. Kaiser wants them down there, do they not? That's the whole issue of when does the emergency end and the post-stabilization begin. Right. So if we have made a determination as an organization to not try to invoke the consent process for post-stabilization, it would be too difficult to get the clinical staff to stop what they're doing, come tell the financial staff, hey, the emergency is over. We step in with the consent form and have an estimate of charges of what happens next. And then the patient either signs it saying we can balance bill them, or they decide to go someplace else. That's just not Tahoe Forest. So we absolutely have not invoked the consent process in the emergency room. We deal with the patients from beginning to end. We bill the whole thing to Kaiser. There's, which I didn't cover in the slides, but there's specific rules on how Kaiser determines what to pay us based upon 2019 data and some other stuff. And so if the payment we receive and how it's applied, we do not agree with, then we go into the dispute resolution process. But that does not involve the patient. That's on us with Kaiser. Yeah, okay.
The patient will only see as if they were in network.
Gotcha, okay.
Director Brennan?
I had a couple questions to help understand this. So at one level, I mean, this looks like it's a consumer-oriented bill, and what I'm wondering if one of the goals of this bill is to relieve the patient of arguing what the amount of the bill should be and putting the burden on the biller, which would be the hospital and the insurance company, to work between themselves to figure out what the amount of the bill should be. Is that one of the things they're doing here?
Well, only if it's out of network. If we're a contracted provider, this doesn't even come into play. Mm-hmm. So these are only for those patients that are coming to our facility that have an insurance plan we may not be contracted with. So it's a very narrowed group that we're really talking about. And what it's trying to do is prevent those patients from being, in essence, surprised by the bill they get from us, because their insurance in the old days would process that out of network, and whatever the insurance didn't pay, the patient was responsible 100% for the rest of it.
Yeah.
And so what they're trying to do is limit that exposure to the patient. And for example, if let's say you come in for your doctor orders some labs. And so it's non-emergency outpatient services. And you come in, you did your due diligence, Tahoe Forest is contracted, et cetera, but lo and behold, suddenly you get a bill from a pathologist because part of what your doctor ordered required pathology, but the pathology company we sent it to isn't contracted with your health plan. How would you ever know that? That's very difficult for the patient to know. So in this circumstance, you cannot balance bill for that pathology. So the pathology company has to treat you as you are in network. They can't balance bill you for whatever your insurance plan wouldn't cover. So it's trying to protect patients from getting these bills from companies. They were never expecting it because we utilized someone that wasn't contracted with their insurance plan. That's what it's trying to do.
So what percentage of our patient visits would fall into the category that this act covers?
It's really, most of the out-of-network we really see here are patients with Kaiser. So, and so those Bay Area folks that have Kaiser, usually they're coming to us for an emergency. Otherwise, they return and go to a Kaiser facility. So we're really only dealing with emergent Kaiser patients. So it's not a huge population.
Okay, that's helpful to know. Thank you.
But take that a step further, Bob, if you would, because I did bring up the Kaiser patient because I know a number of Bay Area friends who have Kaiser coverage. They break a leg skiing. They show up in the ER. They get an X-ray. Yes, it's broken. They don't want any further treatment. That's it. I'm going to pack me for travel. I'm getting in the car. I'm driving home where I have full coverage. Is there a special billing for just that minimum amount of service?
Well, it's still, they sought services at a non-contracted facility. The No Surprises Act applies to the time they're at Tahoe Forest, where we are not contracted with Kaiser. We will bill it to Kaiser as we always do. They will pay it based upon the 2019 data. We will get reimbursed based upon that calculation. If that payment is not accessible to Tahoe Forest, then we can invoke the dispute resolution process with Kaiser. But the patient is out of the picture.
Gotcha. Thank you. Okay.
Does that answer your questions too, Bob?
Yes, that's right. That helps me understand that who it is that would have the balance billing issue. And as a practical matter, who it is we deal with in the hospital that would have that. So that's helpful because it's a pretty complicated law.
Yeah.
And I'm impressed that Crystal knows it that well. I mean, that's very good.
Yeah.
Trust me, I swear to God, every day things change with the No Surprises Act. So it is a constant learning curve, and we're trying to be 100% compliant. And I can tell you, we're probably doing more than a lot of other facilities are. We had to create an estimates department in order to manage the number of estimates we now have to produce for those that are uninsured or scheduled or whatever it may be. So it's kind of an unfunded mandate, once again, for us to find a way to put into place the rules under No Surprises 1020 and 532. There we are.
That was a question I had too, Crystal, was electronically, a lot of this being documentation being done into that versus having to create the wheel for every patient.
Well, we do in Epic have the ability to generate estimates. We have to tweak them somewhat for those that we don't bill for to make sure we pull into that information in as well to be as accurate as we possibly can. And then, as Dale knows, if you are already an existing patient with us, you'll get that estimate through my chart. It's going to say, hey, you have an estimate waiting for you. So we're trying to find ways to utilize the system to touch those patients that may already exist with us. But obviously, we have to ask the patient how they want to receive their estimate, whether they want it in paper, mailed to them, electronically through email. We have to validate the email address. There's a lot that goes into that.
Crystal, this is Mary. Could you remind us of what the consequences are for being out of compliance?
Well, they are talking about financial penalties, but I do not know or have heard of anyone that has been imposed any yet. And I think they're being rather loose about things right now because of the delayed implementation of a lot of parts of the No Surprises Act and the fact that the final rule just came out and that we're learning about it. So I think when we get a little bit more time under our belt, they're going to come back and start enforcing the rules of the No Surprises Act. I will tell you, just the other day, I got contacted by HCI because the last record they have of our billing and collection policies was over 4 years old. And so I was like, what? And she goes, well, HCI has kind of been on hiatus with reviewing everybody's policies and making sure they were current. So we kind of dropped the ball on our end too. So we're contacting all the hospitals just to make sure they get their policies updated because next year we're going to start invoking financial penalties if you're not current. So even HCI is having a hard time enforcing these rules that have come out. So it's been kind of interesting. And our policies are updated now. We're good.
Great. Thank you. Thank you, Crystal.
Harry, you had a comment?
Yeah, just very briefly, these are very clear examples to you and to our audience how the administrative costs to healthcare are trying to climb vigorously. There is a California Office of Healthcare Affordability, and everything there is moving in the opposite direction of affordability in healthcare as well. So it's a very complex set of topics that Crystal covered, but it's certainly raising the administrative burden of delivering healthcare.
Any other comments from our board? Then I'll open up to our audience. Any comments? Well, again, this was for an educational session for our board, and thank you so much, Crystal, for making it a little bit more palatable. And hopefully that we will be able to provide that information to our patients so that there is no surprise when they receive their bill.
I'd say a little more understandable, but not any more palatable.
Oh, okay. Okay, then we're going to move on to item 15, and this is where the chief nursing officer's report was pulled. And I asked to have it pulled because the information that Jan Ida provided was written prior to when some information came out from CDPH. And Louis Ward, our chief operations officer, is going to explain what's going on right now with COVID, masking, et cetera.
Well, thank you, Director Wong, for that introduction. To use Crystal's words, things change very, very fast, and that is very true with COVID as well. So as Director Wong just explained, the CNO report was written a number of days ago, and at that time, the guidance from the California Department of Public Health required that all hospital settings actually had in policy that we would have visitors show proof of vaccination and or a negative COVID test prior to visiting a family member in the hospital. There were some exemptions to that. However, that was, generally the rule. So that was true up to September 17th of this year, of course. And September 15th, the California Department of Public Health rescinded a February 11th, 2022 health order that required those stringent visitation guidelines. And as of September 17th, the health system returned to its visitation policy utilized in 2019 prior to the pandemic. And that policy was titled Visitor for Patient Care Units, numbered ANS 118. The policy was revised this month because the California Department of Public Health still requires that masks are worn in the hospital and that screening continues with regards to visitation. So the policy was updated to include that masks still need to be worn in the hospital and that screening will still occur. But it did remove any need for us to verify vaccination status of a visitor or a proof of a negative test. So in summary, the health system is looking to revise policies. As of 2 years, we have had to include visitation and a number of other items into many of our policies. And so we're continuing to work with the COVID-19 response group to look at those policies, update them as we are seeing more and more relief from the California Department of Public Health. But at this point, there are very minimal restrictions, masking and screening regarding the public entering the building. And so we're happy that we're returning to some level of normalcy here. Happy to answer any additional questions.
Yeah, the way
I have several.
Okay.
Go ahead,
One is it just for visitors, for patients? Are we opening the hospital in general so that people will be using the cafeteria?
So we are discussing the cafeteria. There's a lot to discuss there that actually has nothing really to do with COVID. We've seen a pretty large growth in terms of our staff in the last 2.5 years since the cafeteria was open to the public. And so we are discussing how that opening may look to the general public, but absolutely all visitors, their families, patients, anybody that has any business at the hospital can absolutely use our cafeteria.
And then what will they also be looking at the use of escroage for meetings?
Yes, that is, at this point, there does not seem to be any regulation that would not allow us to use escroage for public meetings.
But they need to look at their policies that they currently are using?
Yeah, we want to make sure that we're accurately moving through the policies and making sure that we don't have an outdated guidance that is in policy, yet we're not practicing that same policy. So there's just been a number of policies that have been created since COVID has started. And so we're going back through the policies and making sure that as we make these changes that the health system is not going to end up in a deficient practice. But in large part, the California Department of Public Health has rescinded this order, as well as they also rescinded earlier in the week a testing order that required that the hospital test weekly or twice weekly all employees that were not fully vaccinated. And so that was rescinded as well, other than, just to clarify, other than our ECC employees. The ECC employees are still required to test twice weekly, as that is a federal order. So they did not rescind that piece of it.
Okay. Any other questions about the regulations that are coming out?
Yeah, this is Bob. I'm just trying to make sure I understand it. It sounds like what has changed is that verification of vaccination rules have been relaxed, but masking still remains. Am I getting it? Is that right?
Yeah, that's the really very simple statement. Yeah. So verification of vaccination, which at times was the difficult part when there's a visitor presenting to see a family member and having to have that discussion could end up as a difficult discussion. So we're very happy that we don't have to have that discussion. But masking is still required in all healthcare settings that provide patient care.
Great, thank you.
Any questions from our audience? Okay, seeing none, thank you so much, Louis, for answering those questions for us.
You're very welcome, Director Wong.
We'll move on to item 16, and these are board committee reports. Do we have any from finance or no, governance hasn't met. Okay, we do have a report from quality. Director McGarry's not available to give it, but I serve on the committee with him, so I'll go ahead and let you know what we've been up to in the board quality committee. One thing is that we went over the validation survey that was in person by Program Beta for our score. And there were several opportunities that came out from their visit, and the quality committee is working on a plan, and there'll be some implementation of some activity that will help with these opportunities that we have. And then there'll be some follow-up at our future meetings as far as how that progress is being made. Also, Alex Crone, who is our patient experience specialist, gave a report on the Patient Family Advisory Council, and they are busy at work. They did a hiatus over the summer, but they're back at work, and their plan for this year is to continue to review patient feedback to see if there's any recommendations they can make to improve the quality, safety, and the patient experience. And they also discussed how they can help in educating the community on the services that our health system provides. And
Alice,
yes.
Alice, if I could, Dale here, along the lines of that Patient and Family Advisory Council, Bob and I were talking about that the other day, and I remember just before Bob came on the board, we had a report from one of the members of that committee to the full board that I thought was extremely informative, and I mentioned to Bob I would hope that we might do that someday soon once again.
From the advisory committee, it was a member?
Yes, yeah.
Okay. I can take that back to the committee to see if they want to do that or if they have information that they want to share as well. But certainly Alex comes and talks about the advisory committee. But it may be the role that they're playing that was of great interest when the board member came.
Yes, exactly. I thought it was helpful. I don't know, Mary, would you concur that it was good to hear from them directly?
Sorry, it took me a minute to unmute. Yes, I would agree. I think the more we hear about the patient experience, the better informed we are.
Okay.
Well, can I interrupt, Director Wong? We do annually have a Patient Family Advisory Council member come to the board in open session. It's normally in August, but because we were transitioning from Lorna Tamman to Alex Crone, we decided to put it off till later this year. So we will do that, Director Chamberlain.
Okay.
We will have somebody come and share what they've been working on and what their focus is for the upcoming year.
Great, thank you.
Thank you, Janet. And then the last thing I would want to let you know is that the board the board quality committee is looking at the white paper that was put out on leading a culture of safety. And there were 6 domains that were identified that we need to work on, or at least look at what we're doing in each of those domains to make sure that we have a sustainable culture of safety. And the focus of each meeting will be one of those domains. So you'll hear more about that as we start it. But I didn't want to leave the opportunity to let you know that National Healthcare Quality Week is October 16th through the 22nd. And this is a time when our healthcare professionals at Tahoe Forest will join those across the country in celebrating their Quality Week. Just to let you know that there is professional work being done in every health care setting to enhance the care delivery, optimizing value and improving outcomes. And the board wants to really recognize Janet Van Gelder and acknowledge her and her team for their outstanding work in ensuring that our health system is dedicated and committed to the highest quality of care that we can. So Janet, if you'll please extend that to your staff as well.
Thank you, and will do.
Any board member reports individually? Any closing comments from our board members? From our staff or our audience?
Excuse me, Alice, I was unmuting. I just wanted to say how gratified I was to hear Dr. Lane's comments and praise of the Administrative Council for their quick response to the physician issues that were presented.
Yeah, that was great to hear, and especially a thank you to our AC or our Administrative Council, because they sure got on it and started collaborating with them. And I think there has always been some things in the background that they've wanted to work on, but this just brought it to the forefront. And thank you, Harry, for your constant emails letting us know what's happening. I think it's very helpful, since we're not all in a meeting together, that we hear via your emails the progress that's being made, because a lot of work is on the behind the cameras. So thank you again. Any other comments? Okay, seeing no hands, then this meeting is adjourned. Thanks, everybody.
Yep.
Good night, everybody.
Good night.